Hi, my name is Sascha Tuchman. I'm a physician at the University of North Carolina at Chapel Hill, where I lead the multiple myeloma and amyloidosis program. And at UNC, we treat a lot of patients with amyloidosis of various types, and we also do a lot of research. And so I'm happy to join this ARC webinar today to discuss treatments for light chain amyloidosis. I know that there have been prior talks on what light chain amyloidosis is and a number of other things that are relevant to this. And so now we'll really specifically and succinctly focus on treatments for AL. And this is more just to give an overview. This is not really meant to be comprehensive, and that a comprehensive discussion of this would definitely take more than 10 to 15 minutes. And so this is just a very brief reminder from the last talk that you probably saw regarding sort of what we call pathogenesis, or what happens in the body to cause amyloidosis, so the actual disease process. And so at the top left, we see what's called plasma cells. So plasma cells are the source of the protein that causes amyloidosis in most people who have light chain amyloidosis. And in many people with light chain amyloidosis, the cells themselves, although they're abnormal, they don't really cause a whole lot of trouble in and of themselves. But what they do that's problematic is that those cells make these toxic light chain proteins that float around in the blood. And these proteins, once they're in the blood, they can stick or deposit in different organs or tissues, such as the heart, the lungs, the kidneys, the nerves, almost any tissue in the body, to create this amyloid protein that's really insoluble. It's tough to get rid of, and it really clogs up organs and impairs organ function. And for people who have symptoms related to amyloidosis, that's really what they feel. They don't feel the cells in the bone marrow typically. They don't feel the protein in the blood. What people usually feel is that amyloid protein that's stuck in organs. And so this is just really at a high level looking at what treatment for amyloidosis, or I should say light chain amyloidosis, looks like. And that currently what we most often do, and what arguably the standard is some form of chemotherapy. And as you probably know, I use chemotherapy just in the terms of that these are medicines that we're using to treat amyloidosis, but this is not chemotherapy like you typically think about, where people expect to lose their hair and get really sick and that sort of thing. Most medicines that we use for treating amyloidosis are not like that. And these medicines, as you can see at the top, these medicines basically function by killing plasma cells. So these medicines go in, they find their way into the bone marrow, and they kill off hopefully as many of those bad plasma cells as possible. What then happens is that those plasma cells, as they die off, they start making or secreting less of that abnormal toxic light chain protein. So the level of those proteins in the blood drops. And then as a result, that protein stops beating up on the different organs. And then what we hope is that the organs can then recover. So the body can recover from this amyloid injury to some degree. This is something that's not well understood currently in terms of how that happens, but suffice it to say that organs can improve once that attack by the light chains and the protein stops. But as you can see on the bottom left, this is really an area of unmet need currently, and it's where there's a lot of research currently happening, including with certain agents that we at UNC and other centers have, looking at new drugs. And what these drugs are geared toward is basically going into different organs and sticking to amyloid protein that's in these organs already and helping to clear it. And this is new because, as I mentioned before, the current treatments that we use outside of studies are really geared toward killing plasma cells, reducing levels of light chains in the blood, and then we basically keep our fingers crossed and hope that the organs heal, because we currently don't have FDA-approved drugs that help to mitigate or reduce organ damage that's occurred by amyloid already. So hopefully these new medicines will help us to do that. And so this is just really, 30 seconds on history. So until this study called Andromeda came out, where a lot of these studies have fun names, Andromeda is one, a big one in amyloidosis that's named after the constellation. These were things that we typically did. So there were a lot of people that did not get stem cell transplant for amyloidosis, and you can see three common regimens listed there. Those are all reasonably tolerable, but not terribly effective in suppressing that bad light chain protein, such that most patients experience an improvement in their amyloidosis. So they were good, but not perfect. Another very standard therapy was what's called high-dose chemotherapy with autologous stem cell transplant, which is just the long medical term for what we more commonly refer to as a bone marrow or a stem cell transplant. Where really the idea behind that is that it's just a way of giving a big dose of chemotherapy that doesn't, we don't think, cure amyloidosis, but it kills off a whole lot of those bad cells. They make less of that light chain protein, and then hopefully organs get better. One of our most effective treatments for amyloidosis, but as you can imagine, it's also the most toxic, where hair does fall out, people have really low blood counts, and this often requires hospitalization, and there's a real risk of mortality. So this is kind of where amyloidosis therapy was before a few years ago when the Andromeda study came out. So Andromeda looked at this common chemotherapy regimen that we use and that I mentioned on the prior slide called CyBorD, which is an abbreviation for medicines called cyclophosphamide. That's the Cy. Bor is bortezomib, which is the generic name for a medicine more commonly known as Velcade, which is the brand name. And the D is the dexamethasone. And so this study looked at patients with newly diagnosed amyloidosis. Everyone got Cybor-D, and then half of patients also got this other medicine called daratumumab, which we'll talk more about. So daratumumab is a medicine that's been around for a long time. It was initially FDA approved in multiple myeloma, which we'll talk about in a second. And we were borrowing it for amyloidosis for many years. So we use it routinely in myeloma. It was FDA approved in myeloma, was not FDA approved in amyloidosis, but we used it regularly in amyloidosis. For those who are interested in drug development or biology, I'll just say that daratumumab is what's called a CD38 unconjugated monoclonal antibody, which, again, if that doesn't mean anything, don't worry about it. That just has to do with the type of drug that it is. And the backdrop for Andromeda was that it was based on some initial pilot studies, so small studies just to sort of test it out initially, which showed that daratumumab was pretty effective and also tolerable in light chain amyloidosis. And just as a very quick footnote about multiple myeloma, we often talk about multiple myeloma in conjunction with amyloidosis. Many people wonder why this always comes up. And basically, it has to do with the fact that multiple myeloma is sort of a cousin to amyloidosis. And what I mean by that is that they both come from those plasma cells that we saw a couple slides ago. They both involve similar light chain and related proteins in the blood, but what the type of damage that they cause in the body is very different. But the reason that multiple myeloma is relevant to amyloidosis is that multiple myeloma is far more common. It's about 10 times more common. And so, from a drug development and clinical research perspective, that means that studies are much more quickly and often done earlier in multiple myeloma. And so so we basically figure out that these things work in multiple myeloma, they get FDA approved in multiple myeloma, and then we borrow them in amyloidosis until hopefully a study is done in amyloidosis. So again, sort of a little tangent there, but this is just why multiple myeloma often comes up in these discussions about amyloidosis. I'm not going to get into this in exhaustive detail. This is just a sort of schematic depiction of how daratumumab kills cells. So you see MM cell that refers to multiple myeloma, but the same concept applies to amyloidosis. Where in those four different little diagrams, you can see the green molecule, that's that Y-shaped thing, that's the daratumumab. It sticks to the surface of the multiple myeloma or amyloidosis cell and then kills those cells through a number of different mechanisms that, again, we won't get into today. And so to tell you a little bit more about the study, so this is getting to sort of the clinical details that are most relevant and most interesting to people with amyloidosis. The Andromeda study, again, was looking at people with newly diagnosed AL, or we know that means light chain amyloidosis, who specifically had heart involvement, which occurs in the majority of people. The study excluded patients with basically severe heart failure. That's what that NYHA class 3B or 4 congestive heart, CHF refers to. So CHF is congestive heart failure. On the next line, you can see GFR less than 20 milliliters per minute. That just means that their kidney function is significantly impaired. And then the last piece was what we refer to as unmeasurable disease hematologically. And basically, all that that means is low levels of amyloid protein in the blood, which usually refers to that light chain protein that we talked about before, where we said that most people have this light chain protein that's in the blood. That's what causes amyloidosis. And so for this study, people had to have a decent amount of that protein in the blood for reasons that I won't get into today for brevity's sake. This is what the study looked like. Again, this is a little bit of a complicated diagram, but this is what study schematics often look like, where you can see that on the left, everyone starts screening. So that's how people go on to clinical studies. And then as people go on the actual study, there's one-to-one randomization. And what that means was that there's basically a coin flip where people are randomized, so one to go on the top part of this, the purple boxes or the orange boxes. And the N equals 388 means that 388 people in total were on the study. And basically, this is a complicated diagram, but all that it means is that pretty much everyone on the study got VCD, which is the same as Cyborg D that we talked about in the last slide. So everyone got the same cyclophosphamide, bortezomib or Velcade, and dexamethasone. And the only difference was that there was this coin flip by which half of patients also got the daratumumab drug, which you see at the top where it says Dara SC 1,800 milligrams. And so people got this treatment. So they got the Cyborg D for VCD for 6 months. And then people who were randomized to receive the daratumumab also continued the daratumumab until they got a total of 24 months or basically 2 years of treatment. So everyone got 6 months. People who were all randomized to the daratumumab also got the daratumumab medication. And then people on the daratumumab arm again continued just daratumumab for another year and a half. And then people were monitored afterwards with no additional therapy until to basically see how people did. And what we see here is some of the clinical data. And again, I'm going to kind of gloss over this so that we don't get too into the weeds with this, but this is what's called overall response. And what this shows basically is that adding the daratumumab suppresses those bad light chain proteins in the blood more deeply and more quickly. So by overall response, we basically mean, so that's the graph. That basically means that we've suppressed that amyloid light chain protein by more than half. And then in the different colors there, you see basically different grades of response. So how good the response was, which just means how deeply we suppressed that amyloid protein. We suppressed it a little bit, we suppressed it more, we suppressed it so low that we can't see it at all. And that's where you see PR, VGPR, CR. Again, we don't need to get into the details of this, but I'll just highlight, for example, the 53 versus the 18, which I have circled, where that refers to complete responses. So that's people who got whichever combination of medication and that amyloidosis protein went down so low that we could no longer detect it in the blood. And so 53% of people who got the Cyborg deal, who got the daratumumab also achieved that complete response versus only 18% of people who got Cyborg D. So adding the daratumumab medication really increased the rate of people achieving that complete response quite a bit. And that's good because the more we can suppress that bad protein, it's not hard to imagine that the higher the likelihood is that these organs will actually heal up. And then on the bottom, you can also see median time to best response. So that's basically how long did it take for those proteins to drop to whatever level they were going to drop to, where it was about 2 months when people got the daratumumab versus 90 days or 3 months for Cyborg D. So summary from this slide is that when we added the daratumumab medication, it suppressed those bad amyloid proteins more, so to a greater depth, and then also more quickly, which is great. This is looking at the data from a slightly different perspective. So this is what's called modified PFS, which stands for progression-free survival. And basically, this is just a combination of different things that can happen to patients with amyloidosis. And so this is looking at time until rise of amyloidosis protein. And then what happens with this is that we do treatment, amyloidosis proteins come down. At some point, they usually come back up. So this is time until that happens. End-stage organ failure, which means somebody's kidneys give out and they have to go on dialysis, or their heart gives out and they have to get a heart transplant, something along those lines, or death, which we know, of course, happens also. And so on this graph, there's the two lines. The top line is the daratumumab, the bottom line is control. I again won't get into detail with this, but basically the higher line means that things went better. Fewer people suffered those events listed above. And so what we see is that there was a very significant increase in patients on who got the daratumumab who did not suffer any of these events, meaning again, amyloidosis protein goes up, end-stage organ failure, or death. So this just basically shows that we really improved overall outcomes for these patients with daratumumab really significantly, which is of course great. This is again looking at organ response. So, as I, the holy grail of treating amyloidosis is not so much just to suppress the bad proteins in the blood, but to really fix the organs, because that's again what people feel and what can become life-threatening in this condition. So this looks at cardiac response or heart improvement versus a renal response, which is kidney improvement. And so what we see is that the purple box, which is daratumumab, there was a higher rate of people who achieved those outcomes as compared to people who got just the CyBorD. So 42% of people who got daratumumab had a cardiac response, meaning that their heart healed up by objective markers, versus just 22% of people who got CyBorD. And then similarly, you can see that a significantly greater percentage of people who got daratumumab also had a renal response or kidney improvement, again, as compared to CyBorD. So basically, this just shows that adding the daratumumab not only suppresses those bad proteins more, but also really facilitates healing in the organs that we care about. And so, other things just to mention about this was the safety. So, of course, we look at side effects, and the quick thing that we can say about that was that safety was really good on this. Adding the daratumumab really did not significantly increase the side effect profile for this. So, it worked better, but really didn't make people feel worse or cause other dangerous side effects, which is great. And as a result of this study, this combination of daratumumab plus CyBorD, so daratumumab, cyclophosphamide, bortezomib, or Velcade plus dexamethasone, was approved in various countries, including the US and in the European continent, for newly diagnosed amyloidosis. So this was really, and I'd add that this is the first combination of medications that was ever approved for light chain amyloidosis, meaning that it's the first time that we ever had anything for treating light chain amyloidosis that wasn't just borrowed from multiple myeloma because it was available. And so someone's unanswered questions, I think this is the last slide, post Andromeda, every question that's answered raises 20 additional questions. So these are some things that we think about today as people who treat and research amyloidosis. First is, how does stem cell transplant fit in the era of dara-CyBorD? So daratumumab CyBorD is really good. It's not the end all be all. Stem cell transplant still could have a role. There are studies ongoing looking at this currently, but I would just say that the way that we most often use this is that most people start on the daratumumab CyBorD. Again, this is with newly diagnosed amyloidosis. And then for people that have really great responses, meaning we really suppress that bad light chain protein in the blood significantly, most of us who do amyloidosis would agree that a lot of those patients probably don't need stem cell transplant, versus patients whose amyloid protein or light chain proteins don't drop that much. Some of those patients may benefit from stem cell transplant to try to suppress that protein further. But again, studies are ongoing to look at this. There's a lot of new agents that we're not getting into today. So there's one called venetoclax, which targets some of the unique biology in amyloidosis. It's a pill which is attractive. That's being researched. And then these other things called bispecific antibodies, which are a new drug class that's FDA approved for treating multiple myeloma, not currently approved for amyloidosis, but there's reasons to think that it could be really promising. Finally, CAR T, I didn't put on the slide, but that's a hot topic in cancer research these days and possibly relevant to amyloidosis also. And the last thing, the really unmet needs still, and I alluded to this earlier in the talk, is how we better break down amyloid proteins that are deposited in organs already. And what I mean by that is that even this daratumumab CyBorD combination is really good. It's totally changed the game in amyloidosis in a good way, but those drugs, including the daratumumab, are still really only targeted at killing plasma cells. And so what that means is that they do a good job of suppressing that bad amyloidosis protein in the blood. And then as we saw, some patients then experience recovery in kidney function and heart function and improvement in other organs, but we still really don't have FDA approved drugs that can go in and mop up the amyloidosis that's deposited in those tissues already. And that's really critical because that's what people feel with amyloidosis. And that's honestly, as said, what can be life-threatening in these conditions. And so that's why it's so important that these studies are ongoing and that medications are hopefully coming, including the ones that you can see listed there, which will hopefully prove to be successful in clinical studies, become FDA approved someday, so that we will then have medications that we can use in addition to things like daratumumab, CyBorD, to go in and now mop up the amyloidosis that's clogging up organs already and causing them not to work right. I think that's the last slide. And so I thank you for your attention today and for joining this ARC seminar. And I would just say that if you have any questions, please refer to ARC. They and we would be happy to answer any questions. So thanks again for attending.